Good afternoon. I'm Robert Page, CEO of MedRepublic. We're here once again today for a medical webinar with one of our top surgeons in Mexico, Dr. Max Greig. Thank you, Dr. Greig, for joining us today.
Thank you so much. It's a pleasure to be here today, Robert.
Great. Today's topic is a discussion on how to care for aging joints. Dr. Max Greig is an orthopedic surgeon based in Puerto Vallarta, Mexico. Dr. Greig studied at the University of Guadalajara, graduated in 1988, completed a rotation at the South Texas Orthopedic Surgery Center in Edinburgh, Texas in 1996. Later completed orthopedic surgery residency in Guadalajara at the Guadalajara Civic Hospital in 1997. And then in 1998, he completed an arthroscopy and shoulder surgery fellowship in Münster, Germany at the Clinic and Polyclinic for General Orthopedics at Münster, North Rhine-Westphalia, Germany. Dr. Greig is a former director of the Puerto Vallarta Medical School, the first medical school in Puerto Vallarta. That's a great honor. He's a former delegate to both the U.S. and Canadian consulates, and he's affiliated of the American Academy of Orthopedic Surgeons, Arthroscopy Association North America, American Association of Hip and Knee Surgeons, the Mexican Association of Arthroscopy and Articulate Surgery, and the Mexican Federation of Orthopedic and Traumatology. So tons and tons of honors, experience, awards. One of the star orthopedic surgeons in Mexico, and a great friend of ours. We've been working with Dr. Greig for more than 10 years now. We've helped him with more than 100 patients over the years. He's done terrific work. We're so happy to have you here on the show again today. Dr. Greig, please, if you could give us just a bit of a background on how to care for aging joints and what you have found to work over the years for your patients.
Well, thanks a lot for your kind words, Robert. Obviously, it's been a great pleasure to work with you and with all your team. It fulfills our mission we have in life about caring for others and providing quality health care away from home. So over the years, it's been a wonderful experience to work with medical tourism and to help people resolve their medical issues with their joints. Something that happens to all of us after we go into our 40s and 50s, we start realizing that we can't do as much as we used to do. And it's because sometimes our joints start to wear out on us and we start losing some of the lubrication that we have in our joints. That's a real normal way of how life goes, that eventually our joints are not as flexible as they used to be, like when we were in our 20s and 30s. Part of a reason that happens is that we have to remember that all joints are recovered by a tissue called cartilage. It's a soft tissue that you find at the end of all of our joints. And it's made up mostly of water, 70% of it's water. The rest is collagen and other substances. And it's very easy for it to break down. We categorize the aging part of a joint in 4 stages. The first stage is when it just starts to dry up and you start getting some cracks inside the cartilage. You don't have any symptoms at that point. And what you do for that, as a preventative measure to help your joint regain its health, you take some of those supplements that you can find over the counter or you can find at some of the stores. There's many of them out there. Several years ago, glucosamine came out in the market. Glucosamine and chondroitin. It's important to take sufficient amount of both substances to help you regain the health of your joints. The 1,500 milligrams per day is what the FDA has approved to help restore the nutrients into our cartilage. So it's important to take glucosamine for periods of 2 or 3 months, with a month or 2 in between of interval, and then go back to doing that again down the road. Since glucosamine came out, other substances have been developed. Some were developed by the French people. It's called diasterine. Diasterine comes in the form of a capsule. You have to take 50 milligrams a day of diasterine over a period of 2 or 3 months. And it also helps restore the cartilage composition. Lately, there is a new component out there. It's called collagen. It's hydrolyzed collagen that resembles a lot the collagen that we normally have in our joints. And that's also important to take on a daily basis. 10 grams of hydrolyzed purified collagen will help give nourishment to our cartilage. So those are some of nutrients that we can find, and you don't really need a prescription in order to have access to those nutrients. On the other hand, it's really important to keep your muscles around your joints healthy and strong. Many times we have overloading problems, especially in the knees. That's where you can have more overloading situations than any other joint. And knees tend to wear out faster than hips and shoulders. So you have to pay special attention to keep your quads and hamstrings strong enough and healthy, so that they can bear some of the load that the knee joint is getting. If you have poor quads and hamstrings, that means that most of the load is going to go on your knee joint, and it's going to affect the functioning of your knee down the road. And then your wear and tear that normally you will have throughout life will be affected severely if you don't have good muscles. In other words, if you have healthy, strong muscles, you will have a healthy knee, and you will have also other healthy joints like the hips and knee and shoulders. So it's important to keep, and regarding the knees, to have very strong quads, very good hamstrings, and make sure you wear proper shoe wear, so that you take some of the impact away from the knees. The knees have an additional structure that we call meniscus, and those little crescent-shaped structures, they take a lot of impact away from the knees. They are like our natural shock absorbers, so they're very useful to help distribute the overloading of a knee. So meniscus is something that you only find in knees. They also tend to degenerate because of impacts that we have received throughout life. Sudden turns, sudden overloading of a knee can cause injury to the meniscus. They are easily repaired with arthroscopy procedures. So going back and talking about the levels of degeneration, we mentioned the stage 1. It was like a breakdown of a cartilage when it starts to get some cracks in it. And those cracks can be resolved taking adequate nutrients and strengthening your muscles around your knees. But if you don't do anything about it, then what will happen is the knees will eventually keep wearing down, and then the cartilage starts showing some areas that are breaking off from the joint. And then those pieces of cartilage, they will float in the joint itself, and they will eventually calcify. So they create like pieces of calcium deposits in the joint that they're very abrasive. They can even be destructive to the other parts of a joint. It's like having some tiny pieces of sand in your knee, and they can create this erosion of your cartilage. So it's important not to get to that stage where your cartilage actually is breaking off, because once you get to the stage, nutrients like I just mentioned and some of physical therapy exercise programs will not be sufficient to bring back the health of your knees. what you could do at that stage is go to your doctor if you're having some symptoms. That's when your symptoms start. You don't have any symptoms when it's just cracking up. Real symptoms start when there's this defects that are forming in the cartilage. So once that happens, you have to see a professional, a joint professional, orthopedic surgeon or orthopedic doctor or rehab doctor who can prescribe getting some joint lubrication injections. Those are special type of medication that's injected in your joint. It's like giving it a lube job so that the joint can function adequately, and you can diminish the wear and tear that's occurring inside the knee. So getting some of those injections, there's many of them out there. It's a supplement to sicken the synovial fluid. Synovial fluid is the liquid that we have inside our joints, and that fluid becomes scarce regarding its lubrication properties. So you can inject some of these substances inside the knee to increase the viscosity of a fluid, and it's called viscosupplementation.
I also had, excuse me, I had a thing called hyaluronic acid injection put in my knee that I've had some issues with over the years. And is that kind of an example of what you're talking about here?
That's an example.
Okay.
Right.
And I remember they were explaining that there were a few different levels of injections you can get that are a little bit more effective, a little more costly, leading all the way to the most expensive, which were stem cell injections into the knee. And
Right.
why is there such a difference in price, and why, as far as you know, and why would one be more effective? Why wouldn't we just go right to stem cell treatment to the knee instead of hyaluronic acid injections, for example?
Hyaluronic acid injections are creating a lubrication for the knee, and you can get a series of 3 to 5 injections with 1 week interval. Or if you're a very busy type of person and you don't have time to go and visit your doctor every week, there is a compound that it's just given once, and you just get 1 shot. Obviously, it's 3 times more costly. But instead of going and getting 3 applications, you can do it all in 1 application. I reserve myself regarding if that's as effective as doing it throughout 2 or 3 weeks. I can't believe that your body requires those
the intervals,
3 injections, so it can build up on itself. If you just give it 1 shot, and just remember, this is not a cortisone shot. Cortisone shots are given to patients who have a very advanced type of wear and tear, and they're not still ready for surgery. And I was going to get to that, where they need something to mitigate the pain they're suffering. So that's when you get into using cortisone shots. But you never want to use cortisone shots beforehand. You don't want to use it when your cartilage is still fairly healthy, or it's not completely bone on bone, because then what the cortisone shot will do, it will create a degradation. It will speed up the breakdown of cartilage. It has been proven in a laboratory. Whenever you get a cortisone shot in your joint, it's just going to hurt your cartilage even more. So I reserve cortisone shots for when the stages are so advanced. This entity is called osteoarthritis. I won't really call it a disease or arthritis as such, but that's how it's classified in the medical world. It's called osteoarthritis. It means it's a wear and tear of your joint, of your cartilage. So in stage 2, I will still reserve myself and not do any cortisone shots. I will give a patient the possibility of this hyaluronic acid type of injections and build it up over 2 or 3 or 4 weeks so that they can have a benefit of getting some help in their joints. Yeah, so the cost depends if it's a concentrated formula or if you're spreading it out and throughout several weeks. I think that's a difference in cost. And then we must remember, in a pharmaceutical world, whoever invented it, whoever has a patent, usually can sell it at a higher price. And then once that patent runs out in time, from 5 to 10 years, then other people can make it too. And to be competitive, they bring the prices down so that they can gain some of the market. The pharmaceutical that originally created the formula has already established. So sometimes when they're trying to break market, they bring the prices down to get in there. So that's why you find a difference in prices.
Okay, it's not because one's more effective than the other.
No.
But and what is your view on the stem cell treatments for the knee? Is that
it's very promising. It's still experimental. They still don't have the hard data on it to really prescribe it openly and offer the benefit of a treatment. Not every patient is a candidate for stem cell therapies.
Mm-hmm.
Why do I say that? Well, you do have, in the cartilage itself, you do have some cells. Those are called chondrocytes. Chondrocytes are the ones responsible of building up cartilage. But let's say this is a patient that cartilage is completely worn out. It's bone on bone, and therefore there's no cartilage left, and there's no cells left. So in those cases, they really are candidates for a knee replacement, or the same applies for the hip. They're candidates for. These are loading joints. Hips and knees are the joints that carry the body weight, so we call them weight-bearing joints. And it's a similar situation in both joints, in hips and knees, where the cartilage just wears out over time, and it creates a situation where the cartilage is gone, and then you have bare bone, and you have bone on bone, and that's when the patient requires a hip replacement or a knee replacement. It's the only way to fix it. There's nothing you can inject. There's nothing you can substitute cartilage with. Yeah. They tried back in the 70s and 80s to inject some kind of gels and try to inject some synthetic materials. They all created foreign body reactions. They had to go in there and remove that kind of stuff they put in there. So once a person gets to advanced stages of wear and tear, then they need to look for a professional who will do a joint replacement for them. But going back a little bit, let's go back to stage 1 or 2 when the patients still have some cartilage, mm-hmm. and they still have some chondrocytes. If you have chondrocytes and they're responsive to treatment, let's say that you're providing stem cells. Stem cells are cells that they're potentially able to make new tissue. That's what stem cell, the idea behind stem cells is this is a type of cell that can create any kind of tissue. So if you inject stem cells in the right environment and you have them interact with your local cells, together they can start creating new tissue. Regarding cartilage, it has been tried in several areas to many universities and many research centers are trying now to see when is the right time to provide a treatment with stem cells. Mm-hmm. And multi-analysis type of research that has been done in many centers, their conclusions are that if you catch it early on, you can have the benefit of stem cells doing something for you. But if you catch it too late, well, the cartilage is completely gone. It was not going to work for you. Not going to work. Then we have another substance. It's called PRP. It's platelet-rich plasma. PRP injections, I also provide them here in my practice. And I especially give those type of injections to people who are in the beginning or in the middle part of their disease, because they carry growth factors, and it has been proven that growth factors stimulates the local cells to do a better job and create more cartilage. But again, even though this has been around now for several years, we still don't have conclusive data that's going to work for everyone. So you have to be kind of selective on your treatments.
Mm-hmm.
So what I just have gone over applies for both knees and hips, which are weight-bearing joints, and those are the stages where that we want to prevent. We don't want to get there. As we grow older and we have the baby boomer generation wanting to do more activities as they age, one of the things that we tell our patients is that, well, if you want to keep your joints healthy, make sure you do some stretching. Make sure you strengthen up your muscles so that your joints don't carry the whole load of the impacts while they're doing their activity. Because some of our patients are in their 60s and 70s, and they're really active. They love doing outdoor type of sports, and they like to do hiking and skiing. And so those type of sports are rough on our joints. And they do it for a period of time, and then they end up coming to our practice saying that their joints are really hurting. And we're studying them, and we are noticing that their cartilage is breaking down. It's faster than usual. So that's when we try to stop it and try to help them get over that degeneration they're going through, and see if we can stop it at one point. We can't prevent it. I mean, we all of our joints are going to break down sooner or later. Some people earlier, some people later, but sooner or later we will have a joint issue. So the more we take care of our joints, the more we baby them, the more we do our stretching exercises, the more we watch over our diets, the more we do regular type of exercise, the longer our joints will maintain healthy. They will maintain healthy. So this is a little bit of a summary of what happens to our weight-bearing joints. I would like to go into talking about the shoulder joint, which is a different kind of situation, but it's a non-weight-bearing joint. But I want to know if there's any questions up to this point.
Not from me. We do have some questions that some readers have sent in, or some listeners have sent in. Would you like me to fire away with those now, or do you want to wait till you're after done with the information on shoulder joint?
Okay, let's go on to the shoulder joint.
Okay.
Shoulder joint is it's a beautiful joint. It's actually one of my favorite joints. I shouldn't say that. I think that the knees and hips will be mad at me if I say the shoulder joint.
No favoritism.
It's a fascinating joint. It's a joint that has gone through evolution. Once upon a time, back in history, many millions of years ago, our shoulder joint was similar to our hip joint. The hip joint is basically a ball and a socket, and that's how our shoulders were back then. So if we will have kept throughout evolution the same type of joint that we had in our shoulders back millions of years ago, we won't be able to stand on our feet in a vertical position. We'll have to stay horizontal and be four-legged creatures, because our shoulders won't be able to function as they function today. As you check yourself, you realize that your shoulder, it's a joint that's very mobile. You can move it in all directions. And if we have a hip joint up in the shoulder area, can you just imagine trying to reach up and brush your teeth or try to comb your hair with a hip joint? You can't do that because there's a limitation. It comes to a point where the hip joint stops because there's bone. There's actually bone covering the ball part of a hip. So that does not allow it to have a full range of motion in 180 degrees. It can go up pretty high. People can really stretch their hips and have forward motions or side motions, but it has a limit. It stops at some point. It hits the bony part of a pelvic bone. So the shoulder has evolved. I mean, the shoulder has become one of the joints that has been studied over time. It was there's people who have gone in to do a lot of research. There's many books and articles written about the shoulder because it's a very complex joint. We do have a ball, but there's no socket. So the question clinicians made was, how does the ball always stay stay in place? Why it doesn't just fall out of place? It does fall out when you have traumatic events, and you have heard about people having shoulder dislocations, but it's usually because of trauma. But normally, in normal conditions, the shoulder is always onto this part called the glenoid that forms the scapula. The glenoid is the articular surface where the head of a humerus attaches to the rest of the body. And the glenoid, compared to the acetabulum is down in the hip area. Acetabulum goes over the head, covers most of the head of a femur. So in a humerus, which is a bone that we have up in our shoulder area, we don't have such bony coverage. It's a very small area that's touching the joint. It's about 30%. It's about a third of a whole diameter of a head, and that's really has contact. So clinicians were asking, how does a shoulder stay connected? And they did some studies, anatomy studies, and biomechanical and physiological studies, and they realized there's a lot of structures that surround the head of a humerus, and they're called ligaments, and tendons, and capsule, and they're all responsible for keeping the head connected to the scapula. But at the same time, what was intriguing is, how do they talk to each other? Because if you have like a tight tendon below, then you won't be able to lift your shoulder upwards because the one below is keeping it tense. So how do they talk to each other? How do they communicate? To let go so that the shoulder can go upward, the upper position, or can go back or forward. So then they started to study the nerve pathways that went up and down the brain, and it's like a symphony. When you do a shoulder movement, just a basic shoulder movement, moving your shoulder around once, it's like an orchestra where everyone knows their role, and they let the part in front is letting go while the part behind is pulling. You bring the shoulder back to the back, and once you bring it back down, there are tendons, ligaments above, they let go, and the ones down below start pulling. So that's called proprioception, and it means that the way the body communicates with its joints, and tells the joint in which position it has to be in. So those nerve pathways were studied too. And when something in the shoulder joint gets disrupted, let's say you have some kind of traumatic event and you get your shoulder dislocated, obviously some of those structures get disrupted. They stretch beyond their limits. Some of the fibers actually break, they rupture, and some of the nerve connections also get affected. So that's why people who have had some kind of traumatic event usually have shoulder instabilities, where a shoulder just pops out. And what has to be done is, of course, we always start with plan A, doing physical therapy to strengthen up your muscles around your shoulder joint, muscles and tendons. But if physical therapy doesn't work, then the person becomes a candidate to repair those structures that got hurt during a traumatic event. But then we have another type of problem that usually happens with people who are over 40. Shoulder instability or shoulder dislocation, it's a very common problem amongst youngsters, people who are in sports, people who are in their 20s or 30s. But people who start getting into their 40s, 50s, they develop another problem. It's called uh, shoulder impingement or rotator cuff problems. Now, what's a rotator cuff? Well, a rotator cuff is a group of 4 tendons that are inside your shoulder joint that are responsible for moving your shoulder in different rotation, different directions. And when there's a spur that grows on the undersurface of acromion where the shoulder connects to the glenoid, but above there's a structure called acromion. Sometimes there's a spur that grows underneath of that acromion, and it hooks on to one of the rotator cuff tendons. And with time, with any of your overhead activities, that tendon itself can rupture, and it can cause damage to the tendon, and it can even detach itself from the head. And that's when surgery is required to go in there, find the tendon, and bring it back over the head and reconnect it to the humeral head. So we see a lot of rotator cuff problems in our older population, and a lot of shoulder instability in our younger population. Some helpful hints regarding how to care for your shoulders is for the younger people. Again, I want to be repeat myself here that stretching is really important before you do any exercise. Making sure you gradually increase your weights and gradually increase the amount of exercise you're doing, and try to stay away from using steroids, cortisone, because they all are proven that just will affect your joint in the long run. And so that's a really important advice for the youngsters. For older people, I recommend that if they feel that they have a shoulder impingement problem, I recommend that they try to build up more their shoulder muscles by going to maybe a physical therapy clinic or signing up in a gym where they can do some light shoulder exercises to build those muscles around your shoulder joint. And many times that's enough to prevent the shoulder from getting the shoulder in worsening the symptoms of a shoulder. But on the other hand, you can't prevent spurs from growing. And we have seen many people over the years that they grow this kind of spur on the undersurface of acromion, and this spur starts to cut in. So what you have to do is set up an appointment with a professional so that they can remove that spur before it actually cuts into the tendon. And then once the tendon is cut, then you have to also consider seeing a professional so that it can be repaired. So you can put the tendon back together so the person can go back doing the things they love to do and going back doing their daily activities. So those are just some generalities on a shoulder joint as well, Robert.
Thank you. This is phenomenal information for me. I'm particularly interested because I am over 40. I'm an athlete, and I've got some issues. So there's tons of information there for me that I'm gonna re-listen to this a few more times and take some notes because definitely very helpful. That is all of our time for the day, though. We've already gone a bit over 30 minutes, and I know we did a lot of you patients sent in some questions, and we've got them all down, and we're going to directly respond to you by email. So thank you for your questions. Thank you for listening in today. We will be back again with Dr. Greig soon for more for more information. And please, we encourage anyone with questions. Specific questions that weren't covered here, or specific questions on other subjects regarding orthopedic matters, to please write in, give suggestions on what topics you'd like to see. We're here to provide information and be a really good resource for patients that are dealing with orthopedic issues. So please, any questions you have regarding Dr. Greig or any other doctors on the platform, please just write in and let us know what we can do to help. Thank you once again, Dr. Greig. Always a pleasure. Very grateful for your time today. And I know you have a busy practice and patients waiting, so all the more appreciative.
I appreciate you guys too.
Okay. Thank you, Dr. Greig. Have a great day.